Good evening, ladies and gentlemen. Today is the day 4 of the heart failure physicians course, supported by the European Society of Cardiology Heart Failure Association and run by Heart Failure Association of India. Today we have a very important sessions today. So the first will be a recap of the previous day by Dr. Arun Gopalakrishnan. Second is the case-based discussions. The next three are case-based discussions. The first is the peripartum cardiomyopathy by Dr. Justin Poole, who has done significant work in this particular topic. Then next is arrhythmia-induced cardiomyopathy by Dr. C. Narasimhan. Then it is chemotherapy-induced cardiomyopathy by Dr. Sanjay Mittal. And towards the end, we have the European Society of Cardiology faculty, the President-elect Dr. Wilfred Mullin speaking on devices in heart failure. So, what is the indication, etc. So, that will be the plan for today. So, over to Dr. Arun for the recap of the previous day and the discussion.
Good evening, everyone. And last week we had 4 elegant talks besides the review of the previous day's sessions. So I'll just quickly give a recap of what happened last week. We had the first talk by Dr. J.C. Mohan on stabilization, acute decompensating heart failure, inotropes, diuretics monitoring, and electrolyte balance. He had given a crisp definition of acute decompensated heart failure as rapidly evolving hemodynamic derangement characterized usually by congestion and less commonly by low cardiac output. And we discussed regarding the natural history. It showed acute decompensated heart failure has a survival at 3 years of 48% and at 5 years only 34%. The 4 hemodynamic subtypes were dwelt upon: wet, warm, wet, warm, dry, and warm and dry, cold and wet, and cold and dry phenotypes. And the low cardiac output with the peripheral hypoperfusion patients constitutes the most lethal. And neurohormonal activation with increased renal sodium absorption constitutes one of the major mechanisms in the symptomatic worsening. And there is a ceiling effect of loop diuretics, because of which we cannot continue the usual doses, and the patients do not respond to the usual doses of loop diuretics. And he also, Dr. J.C. Mohan, discussed an important concept, that is the stress blood volume, which is usually only 30% in a normal person, which increases to 40% in a person with acute decompensated heart failure. And 4 principles in acute decompensated heart failure were touched upon. They include aggressive decongestion, quick initiation of titration of GDMT, physical therapy, and aggressive cardiac rehab. And an 8-step proposed management was dealt upon. The first thing is to identify it and initiate IV diuretic therapy. There are 2 concepts regarding diuretic management. One is natriuresis guided management versus a sequential nephron blockade. Assess response, reassess the patient, determine how the patient is, initiate long-term disease-modifying therapy, discharge and follow-up, and rapid titration of GDMT within 6 weeks. That's what he told. There is ample trial now coming up regarding the natriuresis guided therapy versus sequential nephron blockade, and that was dealt upon. And the diuretic management was discussed, how to start diuretic in a patient who is diuretic naive, and patient who is on a loop diuretic early, maybe double the dose of diuretic to be started with. And there is a concept of using spot urine sodium at 1 to 2 hours, a target 50 to 70 millicurie per liter to optimize the diuretic dosage, and to assess whether urine output is more than 150 ml per hour. And what diuretic to be added upon to loop diuretic. First option would be a thiazide. The other options would be acetazolamide, aminoride, or spironolactone. And natriuretic guided therapy, there is some data to show that there is change in hospital stay and decrease in weight loss. Regarding in-hospital death, it is controversial, and we still need more evidence. Regarding the choice of diuretic of torsemide versus furosemide and bumetanide, This noted that torsemide and bumetanide have higher bioavailability than furosemide, but the transform heart failure trial showed no difference at 1 year follow-up with respect to hard endpoints. And then the concept of ultrafiltration and pharmacological therapy and what happens to the renal outcomes was discussed. And we noted that ultrafiltration was associated with worsening serum creatinine as opposed to pharmacological therapy with diuretics. Then diuretic resistance was discussed upon. It is defined as a failure to increase urine sodium by 90 milligrams per liter despite high dose oral furosemide, that is 160 milligram twice daily or an equivalent over 3 days. The causes of the same can be divided into excessive activation of the renin-angiotensin aldosterone system and distal tubular cell hypertrophy with increased sodium reabsorption. And to treat the diuretic resistance, options will be to change diuretic, add on diuretics, consider bolus doses to be switched over to continuous infusions. And when you add diuretics, consider the additional diuretic, consider diacetyl first, and also bring in SGLT2 inhibitors and other drugs. And it was the impact of GDMT in acute decompensated heart failure on top of diuretic was discussed, and how mineralocorticoid receptor antagonists have been noted to decrease all-cause mortality by 24%, cardiovascular mortality by 23%, and combined cardiovascular and heart failure hospitalization by 28%. A similar improvement in heart endpoints was also noted in acute decompensated heart failure with SGLT2 inhibitors, where all-cause mortality is decreased by 50%. And those who are initiated on SGLT2 inhibitors in hospital for acute decompensated heart failure have been noted to have an early transition from parenteral to oral diuretic. And there is an increased incidence of hospital discharge after acute decompensated heart failure. And these patients tend to have fewer repeat heart failure hospitalizations. And some of the other drugs were also dealt upon. Vasodilators, not a routine use, can be used in patients who have got symptoms if the BP is more than 100 millimeter mercury, but you should titrate to ensure that the BP remains above 90 millimeter systolic and the diastolic pressure more than 65. Inotropes routinely not required, not recommended, and can be used if in sparing cases where the blood pressure is less than 90 millimeter mercury, but remember there's no survival benefit. And electrolyte disturbances are also relevant in acute decompensated heart failure. Hyponatremia is ominous. So is hypochloremia, and that may be an indicator of diuretic resistance. And in that case, you should consider acetazolamide, spironolactone, SGLT2 inhibitors. The role of rapid uptitration of GDMT was brought about by the strong HF trial. Vericiguat is an emerging potential new pillar in acute decompensated heart failure management. And monitoring of these patients, we should have clinical cues besides electrolytes, proBNP, and some of the other measures as well. And then we had an eloquent lecture by Professor Marco Metra, the president of the Heart Failure Association of European Society of Cardiology, on how to add the disease-modifying agents, which is now considered as a quadruple therapy, and is now considered class 1 recommendation because it has significant reduction in relative risk and absolute risk reduction in all-cause mortality, improves survival as opposed to conservative management. And one important thing to note is that quadruple therapy enhances the tolerance of one drug to each other, contrary to the thought that you go sequentially. And suboptimal, despite the evidence coming from a recent trial, there is suboptimal use of quadruple therapy globally, and it's advised to start all 4 pillars early. And quadruple therapy has been noted to increase LV ejection fraction and decrease the potential need for devices. As he showed in some of these large-scale trials from Vienna, Netherlands, and US, there has increase in LV ejection fraction significant proportion of patients over a period of time, and the need for implants actually tend to come down, and there is improvement in NYHA class and vital regurgitation as well. But nevertheless, the use of GDMT is not uniformly taken, even it is showing the real world data. And the most commonly cited reason for not initiating DDMT is the patient remaining clinically stable or symptom free. But That is not the reason why GDMT is to be given. GDMT is given to improve survival and to improve the risk and to reduce the risk of heart failure hospitalization. That's got nothing to do with symptom control. For that, it is diuretic. And again, in this trial, the series from Sweden, US, and Japan, he showed how the incidence of discontinuation of GDMT is becoming a major concern. People do not switch to sacubital valsartan swiftly enough, and that's a concern even in the West. And another aspect that was discussed upon is how to manage patients with low blood pressure on quadruple drug therapy. So for that, what you do is to determine the reason etiology for low blood pressure, see whether they have persistent low blood pressure, and try to eliminate therapies which are not shown to have survival advantage, like nitrates or some of the antiarrhythmics, which may be stopped. And then you can try to, if the patient is asymptomatic, try with initiate with the SGLT2 and MRIs, and the others, it's only last that you consider down titration of GDMT. And while the sequential addition of therapy was the traditional method, the currently accepted method is initiation of all 4 drugs in hospital: ARNI, beta blockers, MRAs, and SGLT2 inhibitors. And ARNI, beta blockers, and MRAs doses are increased on follow-up. Personalized therapy has its role, and there is evidence to say that SGLT2 inhibitors have benefited irrespective of systolic blood pressure. Omecamtiv mecarbil is coming up in patients who got low blood pressure, and there is a role of telemonitoring and telephonic devices for GDMT implementation. Thereafter, Dr. Abraham Oman, the president of the HFAI, gave an eloquent talk regarding how to plan discharge in patients with acute decompensated heart failure, because discharge planning reduces readmissions, improves patient outcomes, and standardizes care transitions and mitigates risk as well. And he posted this several points to ponder. Some important things to note, especially in Indian scenario, is to note that heart failure has a higher mortality than acute MI, which is actually not very well emphasized. Acute heart failure is a severe disease with poor long-term prognosis. And heart failure hospitalization, interestingly, is an opportunity in adversity to optimize treatment, especially with the GDMT. And decongestion is the key. And we have to use clinical tests, laboratory methods, X-ray, imaging like echo, and lung ultrasound are some of the methods that can be used to optimize congestion. There has been an improvement in the use of guideline-directed medical therapy in Indian scenario, but still we are not using the quadruple therapy sufficiently enough. There is only data on triple drug therapy. And there is an Indian consensus on HFrEF, how to reduce what is stabilize acute decompensation heart failure when the patient is off inotropes and diuretics for 24 hours, provided BP and heart rates are acceptable. So early GDMT initiation, post-discharge follow-up has to be given within 7 days, and consider heart failure clinics as a method for follow-up. And he also discussed regarding the issues how low blood pressure can be managed. It was similar to what was by Dr. Marco Metra. And not all renal elevations of elevation of serum creatinine is ominous. There is an entity called pseudoworsening of renal failure, and some patients with mild elevation of serum creatinine actually tend to do better and have better survival as opposed to those who are congested with not so decreased creatinine of GDMT. So decline in renal function during initiation of titration of GDMT are common and expected, and do not overreact to functional worsening renal failure. And there is I need help, an acronym to how to consider patients to be referred to heart failure specialists. And then finally, there was a case presentation one by Dr. Ajay Behel, who discussed a patient with restricted cardiomyopathy who worsened in pregnancy. And interestingly, there is no mention of restricted cardiomyopathy in the WHO classification. And the issues in pregnancy is that RCM, the only drug that you can consider is a loop diuretic. In HCM, there are a few drugs that can be given. In DCM, beta blocker, digoxin, loop diuretic. But DCM and RCM has a high heart failure risk, which is not actually identified in the existing recommendations on heart failure. So that was how it was at the last week's session.
Thank you, Arun, for that nice overview of the last day's presentation. Now we will move on to the presentation by Dr. Justin Paul. Before that, Dr. Chopra, any?
No, I think please carry on. Thank you.
Justin, can you start your presentation? Dr. Justin, as you know, has done wonderful work in pregnancy and heart disease, and he is doing the registry and the randomized control trial on management of heart failure in pregnancy in the Indian setting. Wonderful study which is heading. So over to Justin for this talk.
Thank you, Hari, and thank you, dear HFI, for the kind words and the opportunity. And just a minute, let me, please do let me know if you're able to see the slides.
Yes.
Can make it full screen.
Okay.
Fine.
Yeah.
Dear friends, this is a small short presentation on peripartum cardiomyopathy. So we discuss a patient who's 27 years old, a mother of one child who's 9 months amenorrhea, from a poor socioeconomic background. She has shortness of breath since 2 weeks. Clinically fine, she has tachycardic, borderline blood pressures, tachypneic, and a saturation room here at 92, bilateral rolls, and a tachycardia. And you find that echocardiographically there is dilated left atrium, left ventricle. So right atrium, tricuspid regurgitation, mitral regurgitation. And as you can see that there is a significant LV dysfunction. Now, do we call this peripartum cardiomyopathy? Is this peripartum cardiomyopathy? How do you evaluate this? So then what exactly is peripartum cardiomyopathy? It is a diagnosis of exclusion, onset of heart failure towards the end of pregnancy or within the first 5 months of delivery. This no available other identifiable causes of heart failure and an LV systolic dysfunction with the LVEF less than 45. LV doesn't have to be dilated like what was in this case. So the most important thing is no other diagnosis of heart failure. It's technically a diagnosis of exclusion. This cannot be a blanket dumping diagnosis, which often happens with peripartum cardiomyopathy. Hypertensive afterload mismatch related LV dysfunction or sometimes Stargardt cardiomyopathy are all often labeled as peripartum cardiomyopathy. So disease of multiple etiologies, I will not go into it, just to tell you that when there are more than 3-4 etiologies, it means that it is sort of idiopathic. We are multifactorial. We are really looking into the whatever could be the causes. So many postulations are there, so proofs are there for something. Now, as I told you, though, we say that this comes in the last month, in the first few months, there are cases have been recorded even a little bit earlier or even a little bit later. Now, how do we evaluate a patient with heart failure during pregnancy? This could be due to cardiomyopathy. This could be due to ischemic heart disease, or this could be due to valvular heart diseases, a cardiac arrhythmia, congenital heart disease. What is happening? Sorry. So it could be due to any of these cases. However, in our case, if you look at that, there is no valvular heart diseases except that secondary to heart failure. This is not predominantly valvular heart disease. Well, we also know that this could be a dilated cardiomyopathy. It's not any other cardiomyopathy. Peripartum cardiomyopathy is a type of dilated cardiomyopathy where there is no other reason other than this. This is definitely not an ischemic heart disease. ECG doesn't show anything like that. It's not a congenital heart disease, and there is no cardiac arrhythmia. So we are sort of excluding most other causes of heart failure in pregnancy, and we ultimately boil down to peripartum cardiomyopathy. Now take another patient. So 30 years old lady, hypertensive disorder of pregnancy diagnosed, BP of 140/100 in normal vaginal delivery, sudden onset of shortness of breath and a desaturating tachycardia, BP is 220/110. Echo non-dilated LV with LV ejection fraction of 42. Now, is this peripartum cardiomyopathy? Day 3, with the optimal management of blood pressure, you find that the BP is normal. If she is saturating normally, trumia, the LV ejection fraction is
Just in the slide is not moving. I think it shows the previous slide, I think.
I'm sorry, is it? Are you able to see anything now moving now? Maybe I'll stop
No,
sharing
sir.
it. I'll share again, I'm sorry. Are you able to see this now?
Yes.
Okay. So this is the second case which I told you. On the third day, this patient, you find the LV ejection fraction had improved to 55%. Now, would you call this dilated cardiomyopathy, peripartum cardiomyopathy? Definitely not. This is a case of typically afterload mismatch and LV dysfunction related to afterload mismatch. When the BP is controlled well, you find that ejection fraction has improved. So this is definitely not a peripartum cardiomyopathy. So now that patient, we coming to the patient number one. What will you like to do when the gynecologist asks, as a cardiologist or a physician involved in managing these patients, what will be the mode of delivery? Well, when do you have a preferred vaginal mode of delivery? Generally, by and large, in most heart diseases during pregnancy, vaginal delivery is preferred. Why? Lower risk of obstetric complications, surgical complications, and the hemodynamic shifts are very gradual compared to cesarean delivery. For most patients, including peripartum cardiomyopathy, this may be the most suitable one, except with the patients who are on decompensated heart failure, who are on, of course, we'll just touch upon the other aspects, when they develop labor while they're on oral anticoagulants like vitamin K antagonists, severe pulmonary hypertension, or specific aortopathies, aortic dissection. In case of intractable heart failure, this patient had a heart failure which could not settle down, so she was taken up for cesarean delivery. Now coming to the third patient of the day, you find 32 years old lady, two live children already. On the 10th day postpartum, she is coming to us with shortness of breath, bilateral pedal edema. Rate is reasonably okay, but the echo shows severe LV dysfunction, ejection fraction of 25, moderate MR. No RV dysfunction, she is still lactating. So the question is, should we start bromocriptine? Is there a therapeutic window for starting bromocriptine? These are the questions asked to us in this case by the obstetricians. Does it increase thrombotic tendency? Does it need anticoagulation? So many questions are asked. So looking at that, so how do you manage a patient with a heart failure in pregnancy? First of all, if it's a pre-existing disease with acute heart failure presentation, we definitely diagnose them, basically stabilize them, gather the cardio-obstetric team, identify the comorbidities and manage them, whether there is a hypertension, pneumonia, respiratory infection, there is a pulmonary embolism, rule out the comorbids, look at the natriuretic peptides, echocardiography, definitely diagnose heart failure. Now, if it is an unstable heart failure, just like any other unstable heart failure, optimize the preload, optimize oxygenation, use inotropes and vasopressor, and plan for urgent cesarean section. And you should definitely consider mechanical cardiac support or transplant if she deteriorates or ECMO, if she does not recover, just like any other cardiomyopathy. Just because it is a peripartum cardiomyopathy, if it satisfies the requirement for ECMO or other LVADs, you should give time for recovery. Now, if it's a stable heart failure, in the antepartum period, you can give hydralazine, nitrates, beta blockers, and diuretics. And preferred mode of delivery could be, again, depending on how she is, either cesarean or vaginal delivery. The postpartum period, of course, you cannot use, if you are not you can definitely use some of the ACE inhibitors, some ARNI, beta blockers, MRAs. But however, we should be very watchful if we are using spironolactone for androgenic influence in the child. We can, of course, continue bromocriptine, particularly if there is a severe LV systolic dysfunction. What exactly is this bromocriptine? This is a prolactin inhibitor. This prolactin is one of the possible reasons why there is a peripartum cardiomyopathy. This is a mechanism which I will not go into it, how this can lead to apoptosis and vascular damage leading to LV systolic dysfunction. So if we can block this using bromocriptine, this was a proof of concept study by Dr. Sliva's group where they showed that using bromocriptine significantly reduced death. But it's a very, very small study in 20 patients. However, there is another study, not a very well conducted study from Western Africa, where they showed that using bromocriptine to standard care improved the LV ejection fraction and death. So German multi-study study, which again the people were, ethics committee did not approve a placebo, so they used a 1 week versus 8 weeks bromocriptine and showed that both of them improved. So it's a meta-analysis of all bromocriptine studies. What they showed is that, LV ejection fraction on follow-up, there was a trend to improvement of LV function, but then none of them were statistically significant. So should we give bromocriptine or not? We really not so much aware of the data. The latest data published is from ROPAC, where we found that 85 patients were given bromocriptine compared to 467 who were not given. And what they really found was that there was a significant reduction in maternal outcome, improvement in LV function. So there is definitely an improvement in LV function, but the composite outcome primarily improved by in the fraction of patients who had less than 35% EF at 6 months. So there is no mortality benefit as of now shown. One good thing was that only 25% of the patients were on anticoagulants despite being on bromocriptine, but there was no increase in thromboembolic episodes. Probably this could say that there may not be a great thrombogenic tendency with bromocriptine, but still we consider prophylactic anticoagulant therapy while on bromocriptine. So what do I advise till we get stronger data on bromocriptine? Start only on severe peripartum cardiomyopathy. Start them only if you catch them early. 2.5 mg twice a day for 2 weeks and then 2.5 mg once a day for 6 weeks is what we recommend. And if you stop using bromocriptine and stopping the lactation, use this window to optimize the rest of the proven therapy for heart failure, like SGLT2 inhibitors and RNA. So this is just to show that the use of guideline-directed medical therapy, which is dismally low in Indian population, if it is done well, whatever it may be, beta blockers or MRA or bromocriptine, in these patients fared better. So it is very important whether you're using bromocriptine or not, whatever is the acceptable guideline-directed medical therapy, please ensure that these patients are given. In the antenatal period, we are left up with diuretics, beta blockers, nitrates, ivermectin, and digoxin. And I think this is the last patient for the day. She is a 38 years old primate, and she is 36 weeks of gestation. She is coming to us with a global hypokinesia, LV ejection fraction 35, normal RV function, peripartum cardiomyopathy diagnosed antenatally. Now, her questions are different. Doctor, will my left ventricle recover? How long will it take? How long should I continue the drugs? Common questions you encounter. This is one data from 60 countries, 4,800 patients, a very large data which showed that by 1 year, almost 65% had recovered in North America, while 45% only had recovered in Africa. There is definitely a difference in profile and outcome of patients with peripartum cardiomyopathy based on their human development index. Well, I will not touch upon this thing. What exactly is a good recovery? I personally will believe that LV ejection fraction more than 55, a normal LV-GLS, a stress echo showing normal, and LV function being maintained on gradual drug withdrawal. So a very good article a couple of months back came in the European Heart Journal from the ROPAC group, where they predicted a recovery score. Based on the data they have, what they found that was if a patient had a non-dilated LV less than 53, LV ejection fraction more than 35, a non-dilated, non-widened QRS less than or equal to 80, these patients, the higher the score, greater is the chance of recovery. As you can see that somebody the score of more than 10, there is a 95% chance of recovery. So one message I would like to give you is that if you're handling a patient with peripartum cardiomyopathy, and if you are basically asked a question whether it will recover, these are the factors that favor recovery. You can use the score and give a patient the likelihood of the patient recovering. One of the important things that I would like to share with you is that we need to watch these patients on a longer period of time. There is one data from Scotland where they showed that LV systolic function recovered, and those who recovered, 13% went on to have a decline in LV function without an intervening pregnancy. So just in the absence of pregnancy, the improved LV function went on to come down. So we need to watch these patients very carefully. If you're withdrawing, we have to be very, very careful. So heart failure drugs continue till recovery, whether the drugs can be stopped or de-escalated, which one to stop first, what is the de-escalation? Well, it is all individual opinion. So I told you, I gradually withdraw based on complete recovery, as I told you. If the patients do not recover, if they need heart failure supports, do not have a bias just because they had a peripartum cardiomyopathy. Treat them like any other heart failure. Ensure that these patients get these guideline directed therapies. And yeah, the last point will be with the subsequent pregnancy. This patient was asked to have a boy because the previous child was a girl. Whether what can happen in the subsequent pregnancy, I'll just you take a message only. There is one data that shows that if the patient had an improved ejection fraction, the relapse is much less. But however, even in those with the improved ejection fraction, there is an adverse outcome. So it is not always safe. The latest data from the ROPAC data again compared this 73 patients with no further pregnancies, with the subsequent pregnancies, and 259 subsequent pregnancies, showed that if the patient with the subsequent pregnancy, what you find that is the mortality is higher in patients with the reduced ejection fraction. So what we recommend is if the patient had a reduced LV function, please do not, allow them to have a subsequent pregnancy. Counsel them against a subsequent pregnancy. If the patient is completely recovered, you can permit them, but tell them still there is a risk of reducing LV ejection fraction. As you can see, the blue lines are those who have improved ejection fraction. But however, when you find that between the baseline and the subsequent pregnancy, they had a decline in LV ejection fraction, though better than the other group. So this is a disease that needs a lot of understanding, more research and epidemiology required. There are so much of areas that we need to really work on and understand. So to take home, I would like to share with you that peripartum cardiomyopathy is a diagnosis of exclusion. It is not a dumping diagnosis. It's a diagnosis of careful exclusion. And maximal tolerated GDMT should be given depending on the pregnancy and lactation status. Bromocriptine can be used in severe peripartum cardiomyopathy in the postpartum period. Please remember the postpartum period. Its precise role is unclear. The ongoing studies may clarify us. LV function recovers in 40 to 80 patients about 6 to 8 months. EORP score can be used to predict. Device therapies and heart failure transplants can be considered for peripartum cardiomyopathy as indicated, but we have to remember that there is a chances of recovery there. So wearable ICDs, all these bridges can be considered. Subsequent pregnancy always has an inherent risk, but selected patients with complete recovery may be permitted with caution. And most importantly, a person with a peripartum cardiomyopathy and improved ejection fraction can have spontaneous worsening in the long run without an intervening pregnancy. And thank you very much for your patient listening.
Thank you, Justin, for that wonderful presentation. So some question in the chat box, role of selenium in peripartum cardiomyopathy. Is there any role?
It has sort of a doubtful etiological role. There are questions on that, but I'm not sure whether it is therapeutic, I'm not sure. There is a etiological role, selenium deficiency, that the selenium can be corrected or not. I am not personally aware of a major study on that. But there is some data that selenium deficiency can lead to peripartum cardiomyopathy, but whether correction, I'm not too sure.
What should be the physician's advice for a reference of sinus tachycardia in a pregnant female?
Well, in a pregnancy can produce tachycardia. Usually we often get patients with a heart rate of 110, 120. Just ensure that there are no other secondary causes of tachycardia. Ensure the patient does not have anemia or does not have hypertension, HTP. Manage all that And I usually advise is vagomimetic lifestyle modifications like gentle and deep breathing exercises. This increase the vagal tone, and often you find that sinus tachycardia, the rate comes down. Beyond that, maybe you will have to maybe get an ECG and echocardiogram done, and ensure that things are okay.
Thyroid function also they can check.
Exactly, you are
How,
right. Right.
how to differentiate peripartum cardiomyopathy versus apical ballooning or Takotsubo?
Well, peripartum cardiomyopathy, by and large, as discussed, is in a global hypokinesia. And as you rightly, your question itself says that apical ballooning is different. And apical ballooning at Takotsubo often follows a stress or an emotional or physical stress. And the recovery is much faster than what is expected in a peripartum cardiomyopathy.
Uh,
You can add a
what is
point.
the what is the role of evabrad? These are questions in the chat box, not my questions.
Oh, is it?
Uh,
Okay. I thought you were quizzing me.
no, this is what is the role of ivabradin in peripartum cardiomyopathy?
Well, ivabradin we have not see it is not a documented use, but we have used ivabradin in the antenatal period primarily to control the heart rate. When the heart rate is so high, the cardiac output goes down because the shortening diastolic phase and the filling phases come down. So we have used ivabradin in patients with continuing tachycardia, but we have very few publications here and there. But we still can use. I prefer to use it when the heart rate is more than 100 or more in during pregnancy.
The question is frequent VPCs in a symptomatic in a pregnant lady asymptomatic with normal LV. How safe is to start beta blocker?
I think it should be treated just like a non-pregnant status. Asymptomatic VP, whatever is there is a triggering a thyroid or taking too much of coffee or those kind of things, lack of sleep, those kind of physiological things. You look at it and just watch for it, and maybe you can have a holter if you look at the VPC burden. The burden is generally not mean very insignificant. Often you can leave it as such. You don't need to treat that.
Why is peripartum cardiomyopathy more prevalent in Kerala than in Tamil Nadu? Is there any data like that?
I am not too sure
I
about
am
that.
also not sure about such a
So
data.
maybe our
Maybe
NPAC India study probably can give us inputs. NPAC study is going on in 56 sites in the country with 3 sites in Kerala. So probably that can give some inputs depending in case we have good number of peripartum cardiomyopathies enrolled.
what about the role of GDMT and in this what is breastfeeding? During breastfeeding, what all drugs can be given? That is one common question which is asked.
Yeah, breastfeeding, you can give what shall I say? You can give beta blockers, you can give diuretics, you can give MRAs, watch for androgenic effects in the child, and ARNI and SGLT2 inhibitors. I think data is not clear about that, so better not to give. And ACE inhibitors, NLRP can be given. Losartan can be given in ARB, and maybe I think that's fair enough. Sort of covers the 3 pillars, 3 of the 4 pillars.
Yeah. So somebody has said, sir, I didn't get the point of diastolic load mismatch, which you explained as the differential for peripartum cardiomyopathy.
I'm sorry. Afterload mismatch. What happens is when the LV is facing a pressure of 220 or 240, uh, unlike the 120 or 90 they are used to, sometimes they struggle to handle that afterload, and they start becoming weaker and the ejection fraction comes down. This happens in severe aortic stenosis also. So then what we do is we reduce the afterload. In this patient, when we reduce the afterload by bringing down the blood pressure, left ventricle no longer has to face a 220 millimeter pressure, but it just has to face a 120, 130. So the LV's contractility starts improving. The contractility is matching the afterload very well now, unlike earlier status. I hope I am clear. Hari, you can improve the clarity if you can.
Yeah, I think it is clear. Next question is how to weigh the benefits of full GDMT versus benefits of breastfeeding in peripartum cardiomyopathy, as both can go hand in hand. But already you have answered that question. You can give the four out of the 2 pillars. You can give what is it? Instead of ARNI, you can give ACE inhibitors or ARB. SGLT2 inhibitors is the one which doesn't have much data. The other three pillars can be given. And
One point only I will
bromocriptine.
add is that there is a concern that breastfeeding can worsen, or can impair LV function recovery. But this data was not shown to be true in the IPAC registry from US. So those who were breastfed and those who did not breastfeeding, there was no difference in LV recovery at all. So particularly in a country like India, we'll definitely not advise you to stop breastfeeding unless the patient is too sick where we want to give bromocriptine.
Role of digoxin in peripartum cardiomyopathy.
Well, it is not documented, but then people do give digoxin. Even now, I do give digoxin. It does get the heart rate down. Even in sinus, it gets the heart rate down. So, but then, of course, I think it's off-label or what do you think, Hari, as a heart failure expert?
Yeah, digoxin, I think we use in patients who don't respond and all, we always use digoxin. I think it can be given in patients who are,
It's fine. We give.
yeah, we give.
Reduces rehospitalizations in sick people. That has been shown.
Yeah, that has been, that
Proved in the
has,
Radiance was withdrawal studies that showed some benefit.
Justin, you mentioned if you bromocriptine, if you catch them early in postpartum phase, how early is early?
That data we really don't have, but what we say that is, the first 7 days, if we catch them, like, what not postpartum days, the time of onset, when we catch the patient within 1 day or 2 day of symptoms, that is the time, the benefit is most. This is based on some, what shall I say, finer observations, smaller studies, but I have practically found that also. Maybe I would not have used in more than 15, 20 patients as such, bromocriptine, because, but this is a very unpublished data that earlier the better. So if some patient is coming to you 10 days after the diagnosis of peripartum cardiomyopathy, the chances of its benefit due to bromocriptine is going to be less. So I will say rather the first 1 week, if all the other conditions are satisfied, severe LV dysfunction, BPs are low, the patient is sinking, you can definitely try bromocriptine.
yeah, bromocriptine, only thing is you have to give anticoagulation. That point has to be stressed.
Yeah, if you're giving bromocriptine, prophylactic anticoagulation is always better. Though the ROPAC registry data showed that only 35% were on anticoagulants, the remaining percent were not given anticoagulants, but still there was no worsening or increase in thrombotic tendencies. But we always give a prophylactic anticoagulation when we are giving. There is one study going on called Rebirth study where they are trying rivaroxaban along with the bromocriptine. We'll hope the results throw more clarity.
Justin, you're very popular. There are so many questions still coming in.
Yeah, I think Justin is flooded with questions. I think probably we will stop at this point.
One question, the role of IV immunoglobulin. I think somebody has asked that.
Okay.
Looks very interesting, but then I'm not too sure if the person was asked if they can give some inputs on that, they can share. Hari, you can maybe give some inputs.
Yeah, I think there was a study done by Baikem Boskat, who has written the heart failure, criteria. She has done a study in 2002 actually on IV immunoglobulin in peripartum cardiomyopathy, and it was found that those patients benefited. But subsequently, it was not followed up. And they say that if it is seen in MRI that there is a T1 weighted image shows some edema indicative of an inflammatory process, those patients benefit. But as a routine, I don't know whether anti-inflammatory works. But this study, they showed a small group of patients, it worked. But subsequently, there were no larger studies.
Okay, I think we need to move on.
I think we need to move on. I think we'll move to Dr. Narasimhan's talk, which is recorded. Can Vinay play that recording?
Good evening,
Is he joining?
Chairman, ladies and gentlemen. At the outset, I would like to thank the organization for this kind invitation. Over the last couple of decades, we have understood tachycardias are important causes of worsening heart failure. And tachycardiomyopathy, by definition, is any myocardial dysfunction or heart failure that is wholly or partially reversible after control of the underlying arrhythmia. Broadly, it can be completely due to an arrhythmia-induced cardiomyopathy, or in a person with pre-existing heart disease, it may be an arrhythmia-mediated cardiomyopathy. The situations in younger people with structurally normal heart, they start having atrial arrhythmia and worsen to develop severe heart failure. But the commonest problem that we see in clinical practice are patients with pre-existing heart disease with stable heart function, but they get aggravated due to an arrhythmia. Let's start by looking at this case example. This is a 14-year-old boy who came to us a couple of years ago with significant symptoms of heart failure, was in extremis despite maximal medical therapy, was hypotensive, tachycardia, and he had severe congestion. And ECG at admission was relatively benign looking. With what you see here, I don't know whether we can, let me just take this point. You can see these abnormal P waves which are completely negative in V1. It's not normal to have this in a sinus P wave with varying conduction of because of tachycardia. And this patient had a marked cardiomegaly, and initially there are different labels prior to coming to us. He was labeled as sinus tachycardia, atrial tachycardia, flutter and fascicular VT, and received a combination of antiarrhythmic therapy including ivabradine, which didn't control his arrhythmia. And on admission we found that this patient, let me see whether this plays sometimes, yeah, and that is the initial echo, and you can see severe ventricular dysfunction and mitral regurgitation and TR and worsening heart failure. This patient was started on a combination of antiarrhythmic therapy and a low dose of NORAD, but he didn't improve. Over a period of few hours, the tachycardia accelerated and patient deteriorated, had multiple episodes of cardiac arrest, developed severe lactic acidosis and reduced urine output. He was intubated, ventilated. It took almost about 48 hours for him to stabilize, and then we took him up. This is the right atrium. This is the location of the crista. We find that there is a tachycardia focus here which was ablated. Tachycardia terminates, sinus rhythm comes back, and then post ablation, this is the ECG. And if you see the over a period of 4 months, there's progressive reduction in heart size. This patient continues to do well with almost a near normal LV function now. It's about 8 years on follow up. He was on a low dose of beta blocker as of now. So this is a dramatic example which I wanted to illustrate that even in extreme cases, if you find that there is a tachycardia that is causing cardiomyopathy, addressing the tachyarrhythmia improves cardiac function. And there are several pathophysiologic mechanisms. One is there is an energetic depletion of ATP, microvascular ischemia and oxidative stress, which result in structural remodeling as well as ion channel remodeling, which leads to progressive fibrosis, interstitial fibrosis and ventricular dysfunction. This is another example of a person who was doing very well on post CRT. He was a good responder, EF had improved to 45%, was doing well, came in this with the atrial arrhythmia. Patient was very sick with this atrial arrhythmia, and it was decided in the ER to give him IV ibutylide. 1 milligram of ibutylide was given, and the patient reverted to sinus rhythm. You can see that the CRT has started functioning once the rhythm has come back. However, we had a price to pay. This patient, even though sinus rhythm was achieved, it was at a cost of severe shock, and patient was again started on NORAD, recurrent VT, and deteriorated with falling cardiac output and urine output. Now this is, all of us are familiar, for every particular drug there is a very wide margin of safety between the therapeutic efficacy of a drug and a lethal toxicity of a drug. But in the presence of heart failure, the margin of safety significantly comes down. So this is an important concept I want everyone to take. When you are forced to keep escalating medical therapy to control an arrhythmia, whether it's atrial flutter, fibrillation or PVC, in a person with heart failure, you are doing more harm than good. And that is the reason why non-pharmacological therapy, simple cardioversion would be a better choice in these cases when they are acutely presenting with shock and hemodynamic instability. But the commonest situation which presents or worsens heart failure is atrial fibrillation in adult population. And here again, any drug which we give for controlling an atrial arrhythmia has an effect on the ventricle, and whatever benefit you get by controlling the rhythm in the atrium is offset by proarrhythmia in the ventricle. That is the reason why catheter ablation is superior to best medical therapy among patients with advanced heart failure, systolic LV dysfunction and atrial fibrillation. Catheter ablation over 5 years have shown to improve survival and reduce mortality to the tune of 40%, impressive 40% reduction in death from any cause, heart failure hospitalization and cardiovascular death among patients with chronic AFib and heart failure. Now the German investigator went one step ahead and they randomized patients who are listed for a transplant or LVAD and in end stage heart failure for catheter ablation versus medical therapy, and you find again there is an impressive reduction in mortality over a period of 3-year follow-up. More importantly, you can look at this is the medical therapy, this is ablation group. Patients were delisted from transplantation, transplantation was not required, LVAD was not required in a significant proportion of patients once the rhythm was restored. It can be with pharmacological therapy, catheter ablation or with repeated cardioversion. Again, this is a similar example with advanced heart failure, persistent atrial fibrillation, repeated cardioversions were ineffective, but we realized in this patient the LA was large, he had a mitral regurgitation, he is a patient with sarcoid both in the atrium and in the ventricle, and in this patient we thought catheter ablation of the AFib may not be optimal and he was having this kind of a rhythm. We chose instead to do a His bundle pacing and catheter ablation of the AV node and a very narrow QRS regular thereafter, and this patient has improved significantly again over a period of 5 years. He is almost class 1 now with very minimal medical therapy and anticoagulants. So this does not apply to atrial arrhythmia alone. Patients with LV dysfunction, say a small inferior wall infarction, when that patient develops recurrent non-sustained VT or bigeminy, the ventricular function worsens and these persons do not do well with pharmacological therapy. This is if you have put an ICD in a person with LV dysfunction, recurrent shocks by themselves increase mortality, and there have been several trials to show catheter ablation reduces the recurrent shocks, reduces the episodes of VT, and they do well over a period of time. So in summary, ladies and gentlemen, arrhythmias are common causes of worsening heart failure in a significant proportion of patients. It can be completely due to arrhythmia that the patient has developed heart failure, or a person with borderline LV dysfunction can develop severe heart failure with an onset of an arrhythmia. Escalating antiarrhythmic dosage can be deleterious in this group of patients because of narrow margin of safety, and management of arrhythmia, whether it is with drugs, catheter ablation or devices, improves the long-term outcome of patients with heart failure, and in some cases you can have a dramatic success of patients LV almost normalizing to near normal function over a period of time. I will end here and I will be happy to take any questions. Thank you very much for the patient listening.
Dr. Narasimhan urgently has to go for to some other place. He is in the flight. He may land and he will join the discussion later. So Any points to discuss, Dr. Chopra or Dr. Sanjay? Or shall we wait for?
I think we can wait for Narasimhan to join and get
Join,
on with the
okay.
program.
Okay. I think then now we invite Dr. Sanjay Mittal to give his talk on chemotherapy-induced cardiomyopathy, because it is an increasingly recognized entity because of the increase in malignancies, and more people survive, and long-term follow-up following a chemotherapy. Over to Dr. Sanjay for his talk.
Thank you, Dr. Hari. I think my job is a little difficult because there are two equally potent mortality-related diseases almost competing with each other for the amount of death they produce in the next 5 years after the diagnosis. And one thing leads to the other. So my job is to just start this as a case. I think most of us might have such kind of cases in their lives. 42 years young lady with hypothyroidism, no hypertension or diabetes, no cardiac illness, normal left ventricular ejection fraction, had carcinoma breast and HER2 negative, and was treated with doxorubicin-based therapy. She presented with a history of breathlessness over the last 1 month. And this time, when she presented, she was in frank heart failure with an NT-proBNP level of 15,000. EGFR was okay, 66. Blood CBC was okay, and troponin I was just marginally elevated. And she was in YCH 3 and 4. The ECG did show just tachycardia and a little loss of R wave in the lateral leads, but the echo was horrendous. Ejection fraction was down to just 15 to 20%, and there was elevated filling pressures with a significant tricuspid regression and right-sided head failure as well. Within a month of onset of symptoms, this kind of things did develop. So at that time, when she presented, the blood pressure was a little marginally low. We had to reduce the heart rate by giving ivabradine, and maybe a small dose of ACE inhibitors was started, and then classical heart failure medications were started. And slowly, over a period of time, we could build up, convert the ACE inhibitors to ARNIs, the typical heart failure medications. Bisoprolol was added, dapagliflozin. And what happened was, after 6 months, there was improvement of symptoms. The person was in NYHA class 2, and NT-proBNP had dropped down, but still was above 1,000. The blood pressure was not allowing any further elevation of the medications, and ejection fraction held at 25%. So this is something which was a classical presentation of a person who received doxorubicin and then landed in heart failure. So if I look at the incidence and literature, and this is a beautiful data of 2,600 people who had received anthracycline-related chemotherapy, and they were a follow-up of about 5.2 years, and found that nearly 9% of people did experience cardiotoxicity. And the importance was that today, if we combine doxorubicin or anthracycline-related chemotherapy with adjuvant trastuzumab, the chances of developing a cardiomyopathy or cardiotoxicity actually increased 3 to 4 folds within a span of 1 year, from 9% to about 30% within a span of 1 year. If I look at the types of cardiomyopathies or cardiac involvement in chemotherapeutic agents, it is basically the focus would be the drugs which can cause LV systolic dysfunction. And very importantly, they are anthracyclines, which we are talking about, anthraquinones, monoclonal antibodies, tyrosine kinase inhibitors, alkylating agents, and interferon alpha. There are other drugs which can cause arrhythmias, and as you were hearing Dr. Narasimhan, that perpetual arrhythmias, also tachyarrhythmias, can also lead to cardiotoxicity or cardiac failures. Thrombophilia, thrombogenesis, which lead to infarction, pulmonary embolisms, pericarditis, and myocardial infarction, specifically 5-FUs, topoisomerase inhibitors, tyrosine kinase, and again, a dual modality of cardiotoxicity which can be appearing with these cardiotoxic agents. So, the importance is to understand that the two types of cardiotoxicity. One, which is permanent and related to myocardial necrosis or permanent damage to the myocardial cells. And this is commonly because of the anthracyclines, that is doxorubicin, epirubicin, cyclophosphamide, and docetaxel. Whereas there are other cardiotoxicities, myocardial toxicities, where there is no myocardial necrosis, and so that this toxicity or LV dysfunction is partly reversible. Sorry. And classically, because trastuzumab, sunitinib, imatinib, and lapatinib. So all these drugs can cause reversible myocardial damage, but when they are combined with doxorubicin, unfortunately, a large portion of these cardiotoxicity is permanent. The second part, which I'm going to discuss about, can this myocardial toxicity reverse? So the main concern was the anthracycline-related cardiomyopathy toxicity. And this particular beautiful study where 201 patients who had anthracycline-related cardiotoxicity, where it was defined as ejection fraction dropping down to less than 45, were actually followed up for 36 months with proper treatment of beta blockers and ACE inhibitors, enalapril in this case. And they found that there were three groups of people who actually improved the ejection fraction above 50%. They were responders. People who improved the ejection fraction more than 10 points, but yet less than 50%, or if they did not improve the ejection fraction less than 10 points, percentage points. So a majority of people, if you look at the event rates, the cardiac event rates were best in the responders, those who improved the ejection fraction. And mind it, there were 42% of people who actually showed the improvement to ejection fraction above 50% ejection fraction. Majority of people who did not improve or improved the ejection fraction less than 50% has a dismal outcome within 2 months with a huge event rate. And this is something which is important, that there is almost partial responders, 45%, and 13% people who would not respond to their outcomes. So when we have a situation like this, what should we do? The people who present to us as late as this person who presented to us with an advanced LV systolic dysfunction, there's hardly we can offer anything. And probably if the person remains symptomatic, just like in our patient, we should have a low threshold for transplant, given the surgery or the cancer, which was the root cause of the problem, is been completely taken care of, and there is no reversal in 4 to 5 years. Whereas now the important is that when we should try to act, the dictum is try to catch them early, as early as possible. And what the guidelines are given now as a cardio-oncology guidelines is patient with cancer, we should have a high index of suspicion very early whenever we have to start chemotherapy. And these people have to be, as a class 1 indication, subjected to a risk stratification even before the anti-cancer chemotherapy is started. Once we start them, we have to standardize or triage them into a low risk, moderate risk, or high risk group. And there is a very good guideline which has been given by International Cardio-Oncology Society and HFA. And I'm going to discuss out that in a short while. What happens is, if the person happens to be in low risk, this person can just be on a regular oncology follow-up. Cardiology referral may be required only if the person develops cardiovascular toxicity, which a low threshold has to be there, and the follow-up has to be done by an oncologist. If a person has moderate risk of development of cardiotoxicity, then the person has to be on a closer monitoring by the oncologist, and cardiological referral is a class 1 if the toxicity develops, or there is a class 2 indication that even if the cardiovascular toxicity is not there, there may be a regular follow-up by the cardiologist for the detection of early signs of cardiotoxicity. If the person is in a very high risk group, then the cardiology referral should be done in the very outset, and the person should be followed up with cardiotoxicity and cancer chemotherapy, may be actually evaluated whether it can be changed to a non-cardiovascular toxic group, and the person should be having some cardiovascular protective agents, and this indication is class 2A. So what happens is how to go ahead, how to do a cardiovascular risk assessment. The first one is to identify the pre-existing cardiovascular risk. Higher the age, males, and some genetic predisposition is an important predictor for cardiovascular toxicity. The vascular risk factors, CV risk factors, diabetes, hypertension, obesity, lifestyle factors, lack of exercise, sedentary lifestyle, ECG, transthoracic echo showing residual LV systolic dysfunction. And also, these are agents where there is proven higher cardiovascular toxicity. These are at a high risk of developing of cardiovascular toxicity. So, in a nutshell, what can be said is if a person has anthracycline therapy, and the person has existing heart failure or cardiomyopathy, this person is a very high risk of development of cardiovascular toxicity because of the chemotherapeutic agents. Similarly, if the person is HER2 targeted therapy, the trastuzumab and all, they are a very high risk of development of cardiotoxicity. Similarly, VEGF inhibitors. So the same thing is also in concomitant cardiovascular disease. If the person has valvular heart disease, previous myocardial infarction, they happen to be at a high risk with the anthracycline and HER2 therapies. With VEGF inhibitors, they are a very high risk of development of future cardiovascular events. And this is how we can actually understand the cardiovascular risk before a person is put on chemotherapeutic agents. The second important thing is to understand the severity of cardiotoxicity. So a very severe cardiotoxicity is when the person lands up, like our case, with heart failure and requiring inotropic support. Mind it, our patient did not require inotropic support, but required a tailored therapy because the blood pressure was borderline, and mechanical circulatory support or a consideration for heart transplant. Severe is when the person with heart failure requires hospitalization. Moderate, when the person requires intensification of diuretic therapy in outdoor. And mild is when the person has mild or no symptoms of heart failure and there is no intensification of therapy required. The asymptomatic people can also be severe if the person has ejection fraction dropping down to less than 40, where from the baseline, which was normal. Or if the person has a moderate drop of ejection fraction, that means more than 10% point, yet above 40% to 49%. And if the new ejection fraction drop of less than 10 percentage point, yet ejection fraction means 40 to 49%. And the mild one is if the ejection fraction remains above 50%, yet the GLS, the global longitudinal strain, has fallen more than 15% from the baseline. This is something associated with elevation of cardiac biomarkers, is associated with higher incidence of cardiovascular mortality if the person is left unknown. So what, on the basis of these two factors, that means the likelihood which we detect on the basis of cardiovascular risk profile, and the other thing is the severity of the cardiovascular toxicity. There is a group which is a extremely high cardiovascular morbidity and mortality, and a very low risk of cardiovascular morbidity and mortality. In this particular factor, what we do is we have a guideline which tells us how to go ahead with our decision making. So if a person is put on anthracycline in this high risk group, we have to do an echocardiogram at the baseline, and then on a repeated follow-up, we should do the natriuretic peptides as well as the troponins at the baseline. And in the mild to moderate group, it is class 2 indication to be done, the natriuretic peptides and the troponins. And similar kind of guidelines have been given for us to do a baseline evaluation for these people who are actually to be started on chemotherapeutic agents. There have been guidelines for a monitoring and follow-up. So people who are at a low risk, we have to do a baseline evaluation. Obviously, as I said, the troponin and natriuretic peptide is class 2 indication, but if we have done so, 2B, we can do at a regular interval. But in the low risk group, echocardiogram has to be done at least after completion of 1 year, despite the fact that the person may not be having symptoms, to look at the drop in ejection fraction at least 1 year after the completion of chemotherapeutic agent. In the moderate risk group, there has to be an evaluation. However, there's a class 2 indication to do an echo at the fourth cycle. And then after completion of 1 year, despite the fact the person may not be having symptoms. And 2A indication of doing these markers at a regular interval. And in high risk group, very high risk group, the echo has to be done on a regular interval, and the troponins also are recommended to be done at each cycle to understand whether there is a marker of cardiac injury. And last point is that we have to actually understand the factor of where we are looking at the primary prevention vis-a-vis where we are doing a secondary prevention. So as understood in my previous case, this was a secondary prevention because it was after the onset of the heart failure, and we have to do the heart failure management. However, if the person is to require the further of chemotherapy, then and the person's drop in ejection fraction is mild, there is a class 2A indication to start these people on ACE inhibitors, ARBs, or beta blockers. And the only indication of dexamethasone is basically in definite anthracycline-induced cardiomyopathy, where we have early drops and we can give dexamethasone, where the dose is actually 10 to 1 for the dose of anthracyclines. And these drugs can actually prevent or reduce the chances of cardiotoxicity of anthracyclines. The dictum is act early, detect early, and act early. Why? Because the recovery of cardio function is dependent on when we started to act. If we act within 1 to 2 months of the start of the heart cardiotoxicity, the recovery is as high as 64%. But if we are late, the later we are, the lesser are the chances of us recovering the myocardial dysfunction. A word about the role of GLS. I give you this example. This was a second case of 45 years old lady diagnosed with invasive ductal carcinoma of breast. No other comorbidities were there and received epirubicin for 3 months. The oncology team planned to start the Herceptin also and was referred to a cardiology evaluation. The ejection fraction was very good, 61, and the GLS was absolutely fine, 22% at the baseline. The person was given trastuzumab for 3 months, and the ejection fraction remained 60%. But what we found was the GLS dropped down to 18.7, which was more than 15% drop. And here it was the time that we started as a class 2A indication and a beta blocker and ACE inhibitor enalapril. And we found that when 6 months of the treatment was completed, the GLS did not drop. The GLS was 19.9. And at the completion of, after 1 year of completion of chemotherapy, we had preserved ejection fraction as well as the GLS. So what happens is there are two extreme of cases which I showed you. One too far gone case where nothing probably can be done, probably you're looking at end-stage therapies. And the other one is if we act early, we can save therapy. So the treatment dictum is detect suspect and detect early, a risk stratification very early before we start the chemotherapy, specifically a cardiotoxic chemotherapeutic agent is something which is imperative, class 1 indication. Prompt intervention timely saves a lot of patients, and optimizing chemotherapeutic agent on the basis of our decision is something which is recommended. Thank you. Thank you for your attention.
Thank you, Dr. Sanjay, for that nice presentation. So there is some question in the chat box. What is the role of epirubicin or idarubicin in anthracycline associated cardiomyopathy? I think
No, I
yeah,
think
yeah, it is other way.
dexamethasone probably is the drug. So that's the only thing which has been approved by FDA for prevention of cardiomyopathy. In high-risk groups, it is recommended to give dexamethasone in the dose of 10:1. That means if we have to give 50 milligrams per meter square of doxorubicin or pyridoxine, we give 10, that means 500 milligrams of a bolus of drip of dexamethasone, which is to be given about half an hour in advance of the anthracycline. And this is known to reduce the episodes of heart failure and drop in ejection fraction.
Another question, sir. We physicians often deal with cyclophosphamide in nephro cases and anti-VEGF in ophthalmology cases more than other chemotherapeutic agents. Can you please stress upon the cardiovascular monitoring guide related to this?
I think I have stressed upon mainly the anthracycline-induced cardiomyopathy stuff because this is the commonest one. But as I mentioned, cyclophosphamide is also equally potent cardiotoxic agent, and the guidelines don't differentiate between the molecule. They are saying cardiotoxic chemotherapeutic agent, and that includes cyclophosphamide as well. And the guidelines as far as cardio-oncology clinic, which we run, we treat cyclophosphamide as well in the same group and monitor the LV systolic dysfunction by GLS regularly.
So prophylactic use of, I think you have stressed, but prophylactic use of beta blocker or ACE inhibitor, what is your
There are some papers recently on prophylactic use of ARNI in patients who are undergoing chemotherapy with agents which are more cardiotoxic.
Yes, you are absolutely right. And see, there are 3, 4 molecules: ACE, ARBs, beta blockers specifically carvedilol. And if you have higher oxidative stress, diabetes, or higher risk scenarios, we actually prefer to start them on prophylactic drugs. And ARNIs have a recent paper. So has statins. But all of these have equal amount of ambiguities. For example, SPARE-HF trial, which was on statins, was a negative trial to show any kind of a mortality outcome, although the meta-analysis was benefit in statins. So yes, we are using this thing just to make sure that we give the best, because once there is LV systolic dysfunction, there is a bad outcome. But the good thing is, if we detect early LV systolic dysfunction, whenever there is a GLS drop rather than ejection fraction drop, there's a good outcome if we can change the doses, discuss with the oncologist to see if we can change the molecule and take a lesser toxic, the cardiotoxic agent in place of doxorubicin, pyridoxine. Sometimes what happens is they are agreeing that, okay, the 3 cycles are gone, let's change the molecule. So there are things which can be together with the oncologist discussed and taken a call in the interest of the patient.
I think it is a teamwork.
Absolutely.
I think it is a very close follow-up and close interaction between the two specialties are required. I think that is more important than the timely referral and timely echoes and detection of the early ventricular deterioration should be detected early, and the treatment can be started so that you can. There's another question on iron chelation. Any role?
No. And dexamethasone is basically to actually make sure the cardiotoxic or cytotoxic effect of doxorubicin is prevented. The chelation therapy is not being established as a cardioprotective agent, and the role is limited.
I think somebody wants to see a slide of second case, maybe to ask a question.
No, that is that will be. We'll show the any specific question you can ask.
Yeah,
But the recording will be
specific
shared,
question.
so all the slides will be there in that.
Okay. So is Narasimhan around?
I didn't see him.
I don't know.
Okay. So we'll move to the last talk by Dr. Mullens. He also could not join. So he has recorded and we'll play his the recording. Over to the recording of Dr. Mullens.
Yes.
Hello everybody, I'm Wilfred Mullens. I'm a heart failure specialist from Belgium and the president-elect of the Heart Failure Association of the European Society of Cardiology. It's an honor and privilege to say something about integration and optimization of ICD and CRT therapy in heart failure patients with reduced ejection fraction. I have no conflicts of interest, but I'll try to explain to you how you can get the most out of these device therapies. First, I would like to say something to make you have a change in mindset, and I'll explain all the points later during the presentation. ICD and CRT are life-saving therapies that you must offer to your patients because they're not offered enough. Secondly, the most important thing now is not to learn how to implant conduction system pacing leads, but more to identify the patients that are candidates to receive therapy. Conduction system pacing is important, but it's just a way to deliver resynchronization therapy, but only in coronary sinus failed candidates. You have to change the thinking about device therapy from a sequential approach to a more integrative approach, because there's clearly a synergism between drugs and devices. You have to erase wrong myths, these are untrue stories, with regards to ICD and CRT therapy. You have to replace the terminology of response by disease modification, and you have to make sure that you have an integrated post-device follow-up to improve the outcomes of the patients and the device therapy. Let me first start with a case. This is John. He's 65 years old. He has a non-ischemic cardiomyopathy, a low ejection fraction, NT-proBNP of 1300. He's in sinus rhythm with a QRS of 100 milliseconds, and he is on guideline-directed medical therapy. The question is, should John get an ICD or not? And the answer is absolutely yes. He should be offered an ICD, and that's what we did. And after a couple of years, he actually received a shock because of very fast VT that would have caused sudden cardiac death. So yes, these devices do save lives. But who needs the ICD? Bear in mind that sudden cardiac death is the second leading cause of death worldwide, also in India. So many people die from sudden cardiac death. And the problem is that these patients, when they die from sudden cardiac death, they will not complain. They will not come back to you to say, you should have offered me an ICD. So think about candidates for ICD therapy. Who are these candidates? What determines the benefit of an ICD? You always have to think about the risk of sudden cardiac death divided by the risk of non-sudden cardiac death. And we normally say that in primary prevention, the risk for sudden cardiac death is between 3 to 5% per year. And in secondary prevention is between 10 to 20% per year. So if you're faced with a patient with a low ejection fraction on optical medical therapy in primary prevention, the risk that that patient will die is around 3 to 5% per year of sudden cardiac death. The ICD usage all over the world differs tremendously. In the ICD, more than 50% of the patients who are amendable for the therapy get the therapy. In Europe, it's around 30%, and in India, it's less than 1%. So many patients do not receive the therapy, although their risk for sudden cardiac death is extremely high. It's higher in India than it is in Europe or it is in the States. Bear also in mind that the risk remains high despite the use of guideline-directed medical therapy. You see that in Paradigm and DAPA, which are the trials with Entresto and with SGLT2 and HFrEF, there is still a residual risk of around 3% per year that those patients will die from sudden cardiac death. So if you are on optical medical therapy and you continue to have a low ejection fraction, your risk to die is still around 3% per year. So bear that in mind when you see a patient with a low ejection fraction despite optical medical therapy. They still should be offered an ICD. That is the reason why we put in our guidelines that for ischemic cardiomyopathy there is a class 1 recommendation, and for non-ischemics there is a class 2A recommendation. But still, these patients will have a very high likelihood to die sudden, and they should be offered an ICD. Let me move to the second case. This is Brenda. Brenda is 64 years old. She's a female, a low ejection fraction, large ventricle, NT-proBNP of 1300, so she is a little bit of symptomatic. She's in sinus rhythm with a wide QRS, left bundle branch block, morphology on optical medical therapy. The question here is, should she be offered a resynchronization therapy device or not? And of course the answer is yes, absolutely. This is a class 1 indication. Now let me pose you the question, what is the number one reason for a non-response to resynchronization therapy? Because many people that think that it is lack of resynchronization, lack of good medical therapy. Well, let me tell you, the first reason, the most important reason that patients do not respond to the device is if they don't get the implant. So a no implant is the most prevalent reason for a non-response. So you have to do something about this. You have to overcome the underutilization of this class 1 recommended life-saving therapy. It's a therapy that saves lives, that reduces costs, and improves quality of life. If you look at Europe, we implant around 1 out of 3 candidates with resynchronization therapy. So we're still missing 2 out of 3. And in a normal population, just like in India, you should be aiming at 400 devices per million inhabitants per year. And still we lag behind in Europe, only 1 out of 3. I've been told that in India, the number is less than 1%, so 1 out of 100 of candidates that will benefit from the therapy actually get the therapy. And this is something that you have to tackle. You have to increase the number of implantations with this fantastic therapy. Bear in mind that a wide QRS, so a QRS above 150 milliseconds, is very prevalent in heart failure patients. So more than 30% of your HFrEF population might be amendable for this fantastic therapy. The wider the QRS, the higher the likelihood is that your patient will die from heart failure. So a wider QRS has a poorer prognosis than a narrow QRS. And you have a therapy now that can actually improve this tremendously. When you look at the number needed to treat to prevent 1 mortality after 3 years, you see that for medical therapy like Arrhythmia, it's 27. So you need to treat 27 patients for 3 years with Arrhythmias to save 1 life. For resynchronization therapy, this is only 8. So resynchronization therapy is way more efficient to reduce mortality, to reduce heart failure hospitalization than the latest guideline-directed medical therapies. That is the reason why we put forward a very strong recommendation to consider resynchronization therapy with a class 1 recommendation in patients with a wide QRS or with low ejection fractions who are symptomatic on optical medical therapy. Now let me try to answer some questions that you might still have. Which patient would have the most benefit from resynchronization therapy? The one with a non-ischemic cardiomyopathy or the one with an ischemic cardiomyopathy? Probably most of you think the non-ischemics. Well, this is a wrong myth. Myths are untrue stories, and you have to better understand what heart failure actually is, also to predict which patients are going to benefit most. Because for resynchronization therapy, ischemics derive the same benefit than non-ischemics. Not with regards to ejection fraction improvement, but they do have the same benefit with regards to mortality reduction, heart failure hospitalization reduction, and improvement in quality of life. My patients are not worried about their ejection fraction. They are worried about, am I going to live longer? Am I going to be hospitalized less? And am I going to feel better? And the answer is absolutely yes, to a similar extent for the ischemics compared to the non-ischemics. So please offer these therapies also to patients with ischemic cardiomyopathy who have a higher risk for adverse events without resynchronization therapy than the non-ischemics. The other question is, what about optical guideline-directed medical therapy? Bear in mind that most patients with a wide QRS in the trials of CRT did not receive 100% of the doses of the neuromonal blockers because they don't tolerate them, either because of low blood pressure, because of low heart rate, because of conduction problems. This is linked to bradycardia, hypotension, physician inertia. When you look at the comparison between drugs and devices, in patients who are eligible for resynchronization therapy, so comparing the wide with the narrow QRS, you can see that medical therapy is hardly as effective in the wide as in the narrow. This means that if you give medical therapy to patients with wide QRS complexes, that ejection fraction improvement is only minimal. So wide QRS patients do not respond really good to medical therapy. Very important to think about this. This is different from the narrow QRS. This creates problems because we then tend to wait. We give medical therapy and we wait, but we don't see an improvement in ejection fraction. However, the longer you wait, the more likelihood there will be that your patient will have an adverse outcome. Either heart failure hospitalization, mortality, or more symptoms. That is the reason why we put forward this document with HFA, where we try to overcome the inertia and the sequential approach. The sequential approach means you're diagnosed with heart failure, you get medical therapy, and then you wait. We feel it's time to move on and to phenotype better. So if you're diagnosed with heart failure, and this is based on a wide QRS, it's perfectly okay to already plan resynchronization therapy very early on. You should not wait for a year. So what we do in practice is we schedule the procedure already at the moment of diagnosis of low ejection fraction patients with wide QRS. Because the combination of medical therapy and resynchronization therapy is synergistically beneficial for your patient. Do all these patients need a defibrillator? That's a very difficult question to tackle because CRT reduces the need for ICD because you get improved remodeling. However, most of the times your ejection fraction will not normalize, so your patients will live longer, exposing them to an increased duration of life during which sudden cardiac death can occur. So what we recommend is that you phenotype your patient, and there are 6 things you have to take into consideration. Secondary prevention, that is a defibrillator. Left bundle branch blocks favor my decision for a pacemaker because they respond really well to the therapy. Mechanical desynchrony, pacemaker. Comorbidities, if they're really old, frail, with CKD, for example, then we go for the pacemaker. But if they have genetic mutations, we go for the defibrillator. And if there's a lot of scar, we also will choose CRT-D over CRT-P. So these are not so difficult things to look at, especially when you're a practicing clinician. What about conduction system pacing? Is conduction system pacing equally efficient as cardiac resynchronization therapy? You know there are 2 types. It's either HIS pacing or left bundle branch area pacing. Most of us, almost 99% of physicians in Europe now use left bundle branch block pacing when they go to conduction system pacing, and we don't use HIS pacing as much anymore. First of all, when you would look at literature of conduction system pacing versus classical CRT, the reference for CRT should be adapt response. This was a very large study done in patients with a typical left bundle branch block comparing conventional CRT with adaptive CRT, which is a feature in the Medtronic devices. You see that the number of events was really low. So CRT is a very effective therapy currently with very good outcomes. Only 7% of all-cause mortality and heart failure hospitalization at 1 year. Many of the studies of conduction system pacing versus CRT are favoring conduction system pacing, but they're not really fairly done. This, for example, is a study where you see that there was 20% crossover from the CRT group to the left bundle branch group. This is, of course, a study which is not really objectively handling the topic. When you look at the MELOS study, which was a registry done by the most experienced implanters in Europe, where they implanted more than 2,500 LBB leads, you see their implantation success rate was only 80% in wide QRS patients. So even in the most experienced hands, it did not seem to be so feasible to implant a lead in the left bundle branch area if they had a wide QRS. Also, where is the lead placed? Is it placed at the left bundle? Is it at the fascicular level, at the septum? Not easy to predict at forehand, and many of these patients ended up with a lead which was not typically at the right location. The learning curve for this technology is at least 100 cases in the most experienced hands. The complications rate were up to 12%, which is considerably higher than with classical CRT. And then, of course, there is a lot of debate where to put the lead and which electrical signals to look at before you can actually say that the patient is actually receiving good LBB area pacing. There are also more complications. When you look, for example, at the location of the lead, LBB versus septal, you see that the septal lead position has a worse prognosis than a classical resynchronization therapy lead used in the older studies. And then finally, also there is poor short-term lead performance. There's a failure rate of 1.3% in these cases, especially when you put in the lead in an angulation. This is really important if you're faced with a patient with a total AV nodal block, where you only put in the left bundle area lead. So if that lead actually fails suddenly, your patient will be dead. Finally, there is also an increase of TR. Almost in every observational study, you see a significant increase in TR in patients implanted with these type of leads.
I think, Vinay, you can restart. I think it is stuck.
Yes, sir.
So there is for me a major criticism currently, this may change in the future, to routinely replace CRT by left bundle branch area pacing. There are no randomized controlled trials. There's a huge bias towards this technology. The safety has not been proven. We don't know where to put the lead. The durability of the leads is unsure, and there's more TR. So currently I would stick to classical CRT and not go to LBB area pacing in patients who are candidates for CRT. This is also reflected in the European guidelines, where we still say you should go for classical CRT, not for LBB at this moment in time. A recent document we wrote with the Americans said the same thing. We should go for CRT because the data on CSP are observational. Same is true for a document we just published a couple of months ago with the European Society of Electrophysiology, where we also said the first line therapy should be CRT, and only in failed candidates with CRT you go for CSP. Now when we go back to our patient, we implanted with a resynchronization therapy defibrillator, and after 1 year she ended up in the ICU with advanced heart failure. You see high pressures, low cardiac output. The question then is she a non-responder? Yes, I don't know, or absolutely not. Well, I think we should stop talking about responders but talk about disease modification. Why? If you take all these non-responders to the ICU, you put in a pulmonary artery catheter, and you turn off the device acutely, you immediately see the septal flash reappearing. So this means that in patients that you think are not responding to the therapy, when you turn off the therapy, dysynchrony reappears and the hemodynamics deteriorate. The blood pressure drops, the pulmonary capillary pressure increases, and the cardiac output drops as well. So patients who are deemed to be non-responders are still receiving benefit from the therapy. That is why we feel you should stop talking about response but more about disease modification. And if we would be oncologists, we would be extremely happy with this therapy because all of our patients get at least a partial remission of their disease. Surely many of these patients will still die from heart failure, but we improve the prognosis. We make them live longer with less hospitalizations and with better quality of life. So please stop talking about response, but change response to disease modification. In order to improve the outcomes, we have to organize a dedicated CRT follow-up. The tests that I've listed here, I'm going to tell you some of them, they're not difficult. It's a history and clinical exam. It's optimization of medical therapy. It's offering them a rehabilitation program. Do a chest x-ray, a lab test, an EKG, an exercise test, a device analysis, and an echocardiogram. Not so difficult. Every practicing clinical cardiologist can actually do this. First of all, up titration of medical therapy. Extremely important. Now patients actually tolerate medical therapy way better because their bradycardia is solved, because they have a little bit higher blood pressure. And if you now increase beta blockers and RAS inhibition, you will improve their outcome tremendously. Again, they work synergistically. So it's drugs, devices, and then drugs again. Also pay attention to comorbidities. These are 2 electron microscope images of myocytes. One of them has iron deficiency and the other one does not have iron deficiency. Iron deficiency actually prevents your ventricle from positive reverse remodeling. We've shown that in a prospective trial. So if you actually administer IV iron therapy to those patients who are iron deficient, you see their ejection fraction improving. You have to look at the device analysis. This is not so difficult. You have to look at the battery, at the percentage of atrial sensing ventricular pacing. You can look at the heart failure logarithmics. You have to look for arrhythmias. So there are things to diagnose, there are things to measure, and there are things to program. Programming is very important with these devices, again, to improve outcome. This is an example. This is a patient who told us, I don't feel better, although she received 100% by IV pacing. When you look at the inflow pattern, you see there is still fusion of the early and late filling. And by just changing the AV programming, you can see the separation of the early and late filling occurring. This is extremely important. 40% of the patients have a different setup of their AV timings than the standard out-of-the-box settings. When you put the device in, it's standard programmed at an AV delay of around 120 to 140 milliseconds. And yes, in 60% of the cases, this will actually make your filling pattern way better. But in 40% of them, you have to do it yourself. So you have to check it with echo, and then if you don't have a separation, play with AV timings. Most of the times you have to shorten them to actually improve the filling pattern. If you give a ventricle which is poorly contracting, poorly relaxing, more time to fill, the filling pressure will immediately drop. The patient will feel better within a second. So optimize the AV settings if necessary. This can be done now automatically via the device features, like for example the one which is in the Medtronic devices, but also other device manufacturers have automated AV and LV pacing algorithms, but please check them very quickly by echo. What about atrial pacing? Bear in mind that there is also an atrial pressure loop, which is very complicated as you see here, but it's important that you try not to pace the atrium if it's not necessary. Because if you pace the atrium unnecessary, you have more atrial fibrillation, you have less positive reverse remodeling, and you have less improvement in outcome. So we program the devices at a basal rate of 40 to 50. Of course, if they're chronotropic incompetence, we put on the accelerometers. But if you have a patient who has a sinus rhythm of 60, please allow the sinus rhythm and not going to pace them in the atrium. We also put all of our patients in remote follow-up. Why? Because if you do that, you see that many of your patients do not have more than 98% of bi-V pacing. So 40% of the patients that are actually getting a device do not have 100% bi-V pacing. This is often because of arrhythmias like atrial fibrillation, so you have to tackle the atrial fibrillation to improve the CRT benefit. Many of our patients receive HIS ablation if they have atrial fibrillation. So there are many things you can do in that clinic that actually can improve outcome. It's suboptimal IV timings, it's arrhythmias, anemia, suboptimal lead placement, many things you can do to improve the outcome. This was a study from Boston where they actually looked at all these different factors, and when they actually tackled them via a multidisciplinary care program, they could improve the outcome of their CRT recipients. This is my final slide. If you only would like to read one document, please read this document. This is how you can optimize the implementation of CRT, a call for action. So overcome the underutilization. Please take away the wrong myths with CRT. 3. Change non-response to disease modification. And 4. Offer a structured post-implant care pathway. Thank you for your attention. If you have any more questions, just get in contact with me via email and I will try to answer all your remaining questions. Bye.
Thank you, Dr. Mullens, for that presentation. Unfortunately, he could not join. So if you have any questions, you can email us or put it in the chat box. We can get the reply from him. There's a question on role of CRT in RBB, right bundle branch block. The answer is in non-LBB situations, the recommendation is and the ejection fraction is less than 35, and when the patient is in class 3 or 4, and when the QRS duration is more than 150 milliseconds, it's a class 2 indication, class 2A indication to do a CRT, but the benefit may not be as you get in left bundle branch block. When the patient is in class 2, it is a class 2B indication. And when the QRS duration is between 120 and 140, 149, it is a class 2B indication. And the benefit also is not that as expected in bundle branch. Is the recording of the first class available on, let's say all the recordings are available. You can see in our website. FCM and all will be discussed in the subsequently. Yeah. So all the hfai.co.in, HFAI courses, you will see all the recordings, all the study materials, everything is there in that particular website. You can go, it is posted there. When with such a great percentage of mortality benefit, CRT, Heart Failure Association should mention them as pillar to emphasize and attract more practitioners to refer for CRT instead of a separate chapter in the upcoming guidelines. I agree to some extent. The basic problem in a developing country like India is the cost, and the percentage of people who can afford is very limited. That is a real challenge. And in our registries, even the National Heart Failure Registry of 10,800 patients across in India, the usage of devices was less than 2%. And in any European country, it is always in the tune of around 30 to 40%. So you can see the difference. Probably that is a more, and also inadequate referral also may play a part. But people should, the most important thing is in our Trivandrum registry, what we have found is 50% of the patients had a sudden cardiac death. 50% of the patients had a sudden cardiac death, and 50% only died due to pump failure or non-cardiac causes. So that is very important. So arrhythmias are a very common cause of heart failure. So whenever there is a patient who has a resuscitated cardiac arrest, he should definitely undergo a ICD. And if the patient has a persistent EF less than 30%, then you should consider, and always it is better to wait for 3 months for primary prevention for implanting a device, because nowadays the guideline-directed therapy improves and the outcomes of these patients are better. Sanjay, any comments on that? Dr. Sanjay, are you around? We are not able to access Sanjay. So that is what. So I think people should be aware that these are all life-saving devices. The cost, because many of the procedures are not covered by these schemes like Ayushman Bharat and all. Cost are between 4 lakhs to 7 lakhs. So that is a cost. So that is the most important part in India, I think. Okay, so with that, if any other questions, you can post it in the group or send us emails. Thank you so much. I think we had a very good session today with the recap from Arun, followed by the presentation by Dr. Justin Paul on peripartum cardiomyopathy, then on arrhythmia-induced cardiomyopathy by Dr. Narasimhan, and then chemotherapy-induced cardiomyopathy by Dr. Sanjay Mittal, and the great presentation on devices by the President-elect of the European Society of Cardiology Heart Failure Association, Dr. Mullens. So thank you, everyone. And the next Wednesday, see you all. So we will send you the link, and you can access the website for all the previous recordings and the study materials also. If you have any questions, you can send us emails. And we will be definitely answering those questions. If you have any of those questions are not answered, send us emails. We will be addressing it in the subsequent sessions. So thank you so much and good night, and see you next Wednesday at 7 p.m. So thank you from Heart Failure Association of India and European Society of Cardiology Heart Failure Association. Thank you and good night once again.